Good morning, everybody. Thank you for coming in our national conference, and I hope to be a very interesting meeting with a port of borderline specialties. Our thinking was mine and for the CD Sorot committee to have two stars. One was yesterday, a long day about spine. The other one, it's a discussion about infection. Today will be a long day about infections, in parallel with other subjects from daily orthopedics. We'll show what's happened if the people are coming to you. I hope that. It's a very early morning for the Romanian people, I think. But I must thanks for your coming, for your implication, and I hope in the future very good collaboration in our society, because our intention is to enlarge the borderline specialties to participate, to approach our subjects in a way from all the specialties. Thank you for coming. Have a successful meeting. Thank you. I think it's 8 o'clock. You must start.
Yeah.
Thank you for coming again.
Thank you very much for the invitation. On behalf of the European Bone and Joint Infection Society, it is a pleasure for us to be here and participate in this joint session on the Romanian Orthopedic Society National Meeting. I'm joined here today by Eftimia Giannizziotti from Athens. She's an infectious diseases expert. I'm a surgeon. She's in infectious diseases. This is the way we see that this kind of problem should be handled together, and hopefully we will show you that today. Eftimia?
I would like to thank you in my turn for the invitation and tell that I'm also here on behalf of the SGI, the European Society of Implant-Associated of the ESMID Society of Implant-Associated Infection, which is a very active study group on implants, including the orthopedic implant infection. So with Professor Sousa, we will handle this topic, hoping that it will answer some of your and ours also questions on the hot topic of infections in PGIs.
Okay, without further delay, I will call on the floor to Dr. Rares Berluccio from the Foysar Orthopedic Hospital in Bucharest to tell us about biofilms.
Good morning and welcome to this session on periprosthetic joint infection session that were created in association with the European Bone and Joint Infection Society and the ESMID study group for implant-associated infection. Thank you for joining me in accomplishing a dream of mine, the one of providing high-quality information on this subject in Romania, and I hope that we won't stop just here. It's a great honor for me to start this session. My purpose of this talk is to make you understand what biofilms are in vivo, and what biofilms are in vitro. Bacterial biofilms are often defined as communities of surface-attached bacteria and are typically depicted with a classical mushroom-shaped structure. This classical, well-known cartoon of biofilm depicts just Pseudomonas aeruginosa in vitro under flow cell conditions and when glucose is the carbon source. In vivo, there are no glass surfaces and no mushroom structures. This is probably the nicest representation of where we find biofilm-related infections. We have tissue-related infections and device-related infection. It has definitely been expanded, and there are so many places where we can find now biofilm-related infections. The problem is when we go to the clinical situation, and cystic fibrosis is the classical example of biofilm-related infection. We do not have glass surfaces in the lungs, but we have aggregation formation in the CF lungs. Thomas Jean Scholt published in 2009 in Pediatric Pulmonology a list of patients. And for patient L, a 41 years old male patient, that received during 29 years of disease prior to his lung transplantation, 114 2 weeks antibiotics totaling 1 kilogram of tobramycin, 10 kilograms of beta-lactam anti-pseudomonas antibiotics, and 1 kilogram of nebulized colistin. So it's not just how and how many antibiotics we use. What about the human skin? Trillions of bacteria, fungi, and viruses, small arthropods, colonize the human skin. Generations of researchers have classified these microbes in transient or resident, beneficial or pathogenic, collaborators or adversaries. Microorganisms cover the surface of the skin and reside deep within the hair and the glands. There is interesting data from the dermatological field on this matter. There are 3 sites on the skin, the sebaceous one, the moist and the dry surface. For example, if we take the inguinal crease, we will find plenty of Corynebacterium species and Staphylococci. Lena May published this paper a couple of years ago, and she reported that the upper part of the body is colonized with Staph epidermidis, Staph aureus, Streptococcus pyogenes, Corynebacterium species, and Cutibacterium species, and the lower part of all of the above, and Enterobacter and Enterococcus species. Yvonne Ackermann from Zurich published with her team this paper last year on Cutibacterium avidum that resists on the surgical skin. She reports that prior to decolonization, coagulase-negative Staphylococci, C. acnes, C. avidum, and C. granulosum are the most common pathogens. 10 of her patients had C. avidum. After the first wash, 4 patients still have C. avidum on the skin and other bacteria, and after 3 washes, 2 patients continue to have C. avidum, C. granulosum, and Staphylococcus epidermidis. They were able to do a biopsy of the skin, and with fish staining at the junction between the dermis and the subcuticular fatty tissue, they were able to highlight the presence of C. avidum, and also on the anterior capsula of the hip. There are skin interactions common skin interactions. We have Staphylococcus hominis and Staphylococcus lugdunensis that produce antibiotic that have direct action on Staphylococcus aureus, and Staph epidermidis that produces proteases that inhibit Staph aureus on making biofilm structures on the skin. But do we really understand the biofilm? We understand them in vitro. We know that in the CF lungs we have biofilm, but it's not only biofilm. There is also mucus. And in this atmosphere, we have aggregates of cells and also single cells. But if we think that everything is happening as I first show you, and if we design tests and diagnostic tools for these mushroom-shaped structures, we will definitely fail in the clinic. What about the microenvironment? It is definitely important. In the flow cell, the system creates different gradients of oxygen, nutrition factors. We have quorum sensing and pH gradients. But when you go to the chronic wounds, we have the host influence, and the host creates the environment. We are using more often the term of infection microenvironment, the same as the tumor microenvironment. We have physical factors that enter in the system, like the implant, the impaired vascularization, or inactive or dead host cells. We have substrate, glucose, oxygen, and we have products that are getting out of the system. This creates a totally different environment than the one we have in the lab. And antibiotic treatment is more than just MIC breaking points. It depends strongly on the metabolic and physiological state of the cells, which in turn is governed by the chemical microenvironment. Local starvation of a nutrient or electron acceptor required for growth can cause bacteria to enter in a non-growing state in which their relative inactivity renders them invulnerable to many antibiotic agents. What about chronic and acute infections? We also find planktonic bacteria in chronic infections along the aggregates. Bacteria grow faster in acute infections. This is a nice study that compares community-acquired pneumonia with COPD and CF patients. Most biomass is from single cells, but aggregates still need to be studied. If we think that planktonic cells are found in acute settings and biofilm in chronic infection, we definitely need to revise this idea. The difference lies in the metabolic rate and not the bacterial architecture. And when we compare the median intensity of the fish staining, the most increased one is in the CAP patients. We know that the fish are binding to the ribosomes, and in active cells, like in acute infections, we have plenty of ribosomes. But where are the bacteria in periprosthetic joint infections? Biofilm can grow on the prosthesis and also on the surrounding tissues, can be considered separate but communicating niches. The joint fluid might contain planktonic cells and clumps of detached biofilm. The periprosthetic tissue can be invaded in the infecting bacteria. There can be migration of bacteria between each of these locations, which could contribute to survival. If bacteria from one niche are eradicated by debridement and antibiotics, there is a potential of repopulation with pathogens from the other area. It is not just about the best implant surface to be created. What about pharmacokinetics in porcine models associated or not with implant-associated osteomyelitis? The first model is on cefuroxime, a C3, C4 intervertebral disc model. The author used 1.5 grams of cefuroxime measured with microdialysis, the concentration in different compartments. Their conclusion was that penetration of cefuroxime from plasma in the intervertebral disc was found to be incomplete and delayed. But because of the prolonged elimination, they reached MIC of 6 micrograms per liter. Same model of study on meropenem, 1 gram administered IV over 5 minutes, different concentration in different compartments. Their conclusion was that in order to achieve sufficient tissue concentration in cases of open tibial fracture and chronic osteomyelitis, supplemental application of meropenem may be required. And the third one is on vancomycin. They induce osteomyelitis in day 1 using Staphylococcus aureus. They administer 1 gram of vancomycin, then in day 5, and measure the concentration over 8 hours with microdialysis. Their conclusion was that the lowest penetration was found in implant cavity. Staph aureus was found to reduce vancomycin bone penetration, especially in the implant cavity. Intermittent short-term infusion versus continuous infusion of piperacillin, definitely the continuous infusions achieves over longer time MICs over 16 in all the compartments. What about sonication of implants? This data is from an in vivo study. We can see even that when we have 160,000 MICs of gentamicin and we use sonication, we are able to still culture some strains of Staph aureus. Under microscopic, on the left side of the slide, we have MICs of gentamicin of 160, and on the right, 16,000. In the second part of the slide, there is a reduced inflammation, but still in both conditions, we are able to see in the implant cavity Staph aureus. We definitely need to shift from this to something like this. So we could understand what happens in the body. We have 3 main events that happen all the time: aggregation and attachment, growth and accumulation, disaggregation and detachment. We always have planktonic bacteria and aggregates. This is what we need to treat, and this is what definitely we need to diagnose. What about environmental biofilm and healthcare associated infection? This is a nice study from Germany, from Klinikum Bayreuth. They have some sporadic outbreaks of MDR pathogens, mainly Pseudomonas aeruginosa. They had some problem with this bug, Clogmia albipunctata. What is interesting about her is that she deposits eggs in the water, and they develop there. They done endoscopy on operating room 7 on the sink. They were able to harvest some biofilm, and you can see on the left image some Clogmia that are popping from the sink. Around 7 in 57 seconds. You can find the video online. They've done some fish staining on the biofilm, and in green, orange, they highlighted the presence of Pseudomonas aeruginosa. They done, when compared with an MIC, is definitely a resistant strain. They were also able to catch one and do a cross-section of the leg of a Clogmia, and The claws were embedded with biofilm, and the fly was taking part of the biofilm from the operating room into the hospital. This is definitely a connection between environmental biofilm and hospital-acquired infection, and definitely it is relevant. In conclusion, in vitro definitely is not in vivo. We need to understand the microenvironment. We need to diagnose biofilm. Fish techniques can do this. There is a need for improved diagnostic methods. We need to improve our biofilm testing and therapeutic options, not biofilm in every infections. We need more basic research and the shift from the clinic to from the lab to the clinic, and we need to prevent chronic infections. Thank you.
So next speaker is Professor Sousa to present us the current guidelines by the EBSIS.
Good morning, and that's exactly why biofilms are important. They elicit very low inflammatory response in the body, and they elude our traditional diagnostic criteria. And that is why we at EBSIS try to find a new PGI definition that would help clinicians, experts, and non-experts to reach a diagnosis. What I'm going to try to do in the next few slides is to help you go through the diagnostic procedures and how to get to a final diagnosis, because it is very well documented that infection is really present in cases that we think is aseptic, and especially true if you don't look for it, because obviously clinical judgment, just looking at the patient, looking at the case and see is it infected or not, is clearly not enough. You need to do a protocol, systematic diagnostic approach to reach a correct diagnosis. And a correct diagnosis is very important to prevent further complications. So these are the new EBSIS diagnostic criteria for prosthetic joint infections, and I will try to lead you through them and how we can use them to get to a final diagnosis in the clinical practice. So what we do is preoperatively, you need to start with the eye index of suspicion. Whenever you're facing a joint that is failing somehow, or is painful somehow, you need to suspect infection might be the cause of it. And then the workhorse of preoperative diagnosis is joint aspiration. And then, of course, intraoperatively, you need to do your microbiology search and perhaps histology. And we'll speak briefly about nuclear medicine, but of course, I know we have a very well-respected speaker on that, so we'll go over it very quickly. So, before surgery, when you're in your practice, in your office, and you're looking at a painful joint, there are some clinical features that are important. Of course, comorbidities of the patient are important, not only to assess the likelihood of the prosthesis getting infected, but also the prognostic of the treatment. It's very important to ask the patient about how was the wound healing after the initial procedure. There is very well known documentation that the wound complications, mainly persistent leakage or small dehiscence or small superficial infections, they highly increase the risk of subsequent PGI. So this is a very important clinical feature that you need to look for. And also, of course, the chronology of symptoms. If you have a prosthesis that is doing okay, and then after an episode of sepsis, of bacteremia, it gets painful, of course you need to suspect about infection. And also, if the prosthesis fails very early, we know that most of early failures are caused by infections. Aseptic loosenings are usually later in the lifetime of the prosthesis. So if you have an early failure, also very importantly, think about infections. And of course, physical examination, we always do that. That's part of the standard investigation of the patient, but it is often very innocent looking, it's very variable. Of course, if you find fever, if you have redness, joint effusion, of course, that is highly suspicious, but it's got a very low negative predictive value. So it doesn't mean anything to say that the patient is not red, so there is not an infection. It doesn't work like that. And of course, if you have a sinus tract, or if you have direct communication of the prosthesis with the outside world, and of course those are confirmatory signs for infection, but they don't occur often. And of course, most of us will do some kind of laboratory screening. It is very important not only to assess the likelihood if you have elevated CRP or elevated ESR, there's a higher likelihood of infection. But if you notice in our definition, elevated CRP only makes infection likely. It's not a decisive diagnostic factor, because there is extensive evidence that there are a lot of infections that are seronegative, meaning that they have normal inflammatory values, normal CRP, so it should not be used to exclude the possibility of PGI, but of course it's important to assess the patient. And of course, if you have a painful prosthesis, maybe some elevated CRP, you will need to, or if you suspect clinically of infection, you need to do a joint aspiration. Joint aspiration, examination of the synovial fluid is your main choice for diagnosis preoperatively. The main discussion here is, should you do it always, or should you do it only in selected cases? And if you should do it only in selected cases, if you do it always, you have to do all the cases before you do the revision arthroplasty. Go and do, that's relatively easy for the knee, but for the hip or for the shoulder that are not easily accessible, it's perhaps some more logistically harder to get all those patients to do a puncture. But if you do it selectively, what are your criteria? This is an open discussion. This is our criteria, our own institutional criteria: elevated CRP, early failures or previous failures or repeat revision failures, or all those clinical suspicion risk factors. And we have found that it's very high sensitivity, so very high negative predictive value. So these are our criteria, but this is not like some written in stone rule. So if you're going to do a joint aspiration, how do you do it? You should stop antibiotics, or rather not start them at all, but if the patient is already put under antibiotics for a suspicion of infection, you should stop it for at least 2 weeks, because we know that there is a very high rate of false negatives if you do the puncture while under antibiotics. Of course, you need to do it in sterile conditions, imaging guided if needed, especially for the hip or from other less accessible joints. And you should send the fluid for multiple investigations. You should send them for microbiology, of course, and it's very helpful if you inject the fluid directly into blood culture bottles. It will increase sensitivity, especially for demanding microorganisms. It reduces manipulation and so the rate of possible contamination, and it also offers you a quicker response. So talk to your laboratory if you're an orthopedic surgeon, and talk to your orthopedic surgeon if you're a lab guy. This is very helpful. And of course, differential leukocyte count, this is very important, and also, of course, alternative biomarkers that should be investigated. What about microbiology results? If you have no growth, then because of biofilm issues, Rares told you there are some planktonic bacteria around, but most in chronic infections are mostly biofilm, so it is not unusual to get negative culture results in infected joints preoperatively. So they have very low sensitivity, should not use these results to rule out infection. And of course, if it is positive, then infection is likely. But although you need to think there's not a perfect match between intraoperative and preoperative, usually intraoperative are more comprehensive, more results are found than the joint aspiration itself. So differential leukocyte count, I will go over it in the biomarkers talk. But mainly this is our interpretation. If you have very high leukocyte count or very high proportion of polymorphic nucleus, then you can be sure. And if you have no other alternative explanation for this, you have no metallosis, you have no crystal arthropathy, you're not in the early period, you're not in a fracture. So no alternative explanation for this. This is very likely that you have an infection. And if you have a very low leukocyte count or very low proportion of neutrophils, then you can be more sure that it is not infected. And of course, alternative biomarkers that we'll talk later on today. So often you get a dry tap. You try to do a tap and you can't get enough fluid, so what to do then? There's this rule that's very important. The volume of fluid does not distinguish between PGI and aseptic. This is a dry tap, this is not infected. That is not the case. There is a significant proportion of PGI in dry tap cases, so what are our alternatives? Well, the first alternative is simply to try aspiration in another date, 2 weeks from then, and often you can get liquid from a joint that you couldn't before. And this has been shown. The other alternative, and I recommend that you do this only if you are in a completely aseptic environment, is that you can do instillation of some fluid and then aspirate it. Of course, you're not very sure, you're not completely sure that the same volume you put in is the same volume you get out. So every measure that's around concentration, so leukocyte counts, biomarkers, and so on, you will not be able to do that if you do this technique, but you can culture it, you can do microbiology, and it has been shown that it's very effective in getting the bug. Percutaneous biopsies is also an alternative. You can do the soft tissue sampling, the synovial samples, you could do the bone implant interface sampling, and these are very helpful. And when we take the patient to the OR, when you do like hips, for example, that we take them to the OR, then we go over this every step of the way because we only want to take them there once. So we do all of this. And also there are some authors that recommend arthroscopic biopsies. We don't have experience with this, but it's a possibility. And of course, imaging is also very important for us orthopedic surgeons. We always do an X-ray, even if you don't know what we want the X-ray for, we do it. But of course, it's very important. It's especially for alternative diagnosis, not to diagnose infection, and to prepare the revision surgery. Ultrasound or CT scans are also very important. It can help you guide aspirations, guide biopsies, evaluate extensional abscess, plan your surgical approach is very helpful. And of course, nuclear imaging, of course, I will go through it very quickly. The traditional is this 3-phase bone scintigraphy, and you have the positive scan is it lacks specificity, and there's a lot of causes, especially in the early period after surgery, so low specificity. But if you have a negative scan, then this means there's nothing really metabolically going on there, and this got a very high negative predictive value. And the same for white blood cell or antibody scintigraphy. We should do it within the 2 years after the prosthesis because the traditional scintigraphy has no value there. Or if the traditional scintigraphy is positive, then you do this. And if you get, again, the negative result is very high negative predictive value, and positive results slightly increases your specificity, it makes infection likely. But I'm sure Professor Gleiden will go over this anyway. So the alternative is you can add bone marrow scintigraphy to the leukoscan, and then you'll somehow map the bone marrow, the ectopic bone marrow, and then subtract it from the white blood cell scintigraphy, and then you get your infected diagnosis. Well, but then you get to this point that you're going to operate on the patient, and even if you suspect infection, if you use these criteria, these EBGIS criteria, what we have found, it is the one that offers, comparing to the other definitions out there, is the one that offers the highest agreement between the preoperative and the final results, and is the one that is better at ruling out PGI in the preoperative stage. But then, of course, you need to go for surgery, and then you need to collect interpret your findings. And purulence was somehow removed from the criteria because there's a lot of potent inflammatory conditions like crystal arthropathy or metallosis that can mimic the subjective interpretation of purulence. So purulence makes infection likely, but not, of course, not confirmed. And you should collect a lot of multiple deep tissue samples because there's this low-grade biofilm-related infections often. And what has been determined is that you need at least 4 samples to get to an acceptable sensitivity for microbiology samples. And it also increases the chance of isolating the microorganisms, and it also helps you interpret the findings because often infection is caused by those bacteria that colonize the skin. So if you got one positive sample, it's difficult for the lab to tell you this is a contamination, this is a real infection. But if you have multiple tissue samples and if you have multiple positive cultures, then it's easier to say that this is a real infection. Harvesting technique is very important. You should use clean and dedicated instruments. You should collect from multiple sites, and you should store immediately after you harvest your samples. It is not correct to leave it at the nurse's table and then at the end of the procedure put it in the bottles. It has been proven that it offers a lot of false positives, or they get contaminated in the table. So you should store them immediately after you collect them. And of course, biofilm retrieval is very important in this case. When you take the prosthesis out, the most well-known biofilm retrieval technique is sonication. Sonication is something that, like an ultrasound of a bath of ultrasound that releases the biofilm from the prosthesis, then you culture the fluid that you get. But if you use sonication alone, it is not better than using multiple tissue samplings. What has been shown is that sonication really adds to multiple tissue sampling. If you don't have sonication, that's not a problem. Multiple tissue sampling is better than sonication alone. So sonication is not this potent weapon that solves all our microbiology problems, but it should be added as an extra technique, an extra sampling, and this combination offers the best sensitivity. And histology is also something that you can do. Direct visualization of pathogens is highly specific, but the presence or concentration of acute neutrophils correlates closely with infection. That is very well established, and it can be used as frozen section if you have an experienced pathologist. It can do it as an intraoperative tool. It has been shown to be very concordant with definitive results. The problem with what's the ideal cutoff for interpretation? There are a lot of proposed cutoffs. We established this one, or adopted this one. This is very well known in the literature. But this is a highly specific cutoff, but it lacks some sensitivity, especially for some low-grade microorganisms. And if you are interested to know more about that, please read this paper from the colleague from Barcelona, from Bori. It tells you about the history of this cutoff. It was mainly used for acute infection diagnosis. And if you adopt a lower cutoff, like the presence of more than 5 neutrophils in a single high-power field, what is the value of that? Well, it has been looked very recently from this patient from Oxford, the paper from Oxford, where they looked at a lot of different cutoffs, found in the literature, they found that this more than 5 neutrophils in a single high-power field, using our definition, the EBGIS definition, showed a very reasonable acceptable specificity of 86%, so it makes infection very likely, but it's not confirmed. And histology has the added advantage that it can offer you other explanation of other modes of failure, like particle or combined type or fibrotic. So it's very helpful to do systematically. And you can understand that this is very difficult. You need to work in a multidisciplinary teamwork if you want to interpret this, all these combined findings together. And this is what we will find at the EBGIS meeting next year. Thank you for your attention.
Thank you, Ricardo, for this thorough presentation. And we move on to the next speaker. It's Professor Florescu, Associate Professor on Infectious Diseases at Carol Davila University of Medicine and Manager of the Clinical Hospital for Infectious Diseases from Bucharest, to talk us about the epidemiology and etiology of prosthetic joint infection.
Thank you. Good morning. So I'll talk about an infectious disease more part of these prosthetic infections, about the etiology and epidemiology of prosthetic joint infections. So, as Professor Sousa told us, there are many definition criteria, but the one that we know as infectionist is one of the following, at least: presence of a sinus tract communicating with the prosthetic joint, presence of purulence without another known or suspected etiology surrounding the prosthetic device, and of course the histopathologic examination of periprosthetic tissue, with that Professor Sousa already told us, presence with the granulocytes on the high power field more than 5, the synovial fluid with elevated leukocytes, and at least 2 intraoperative cultures, positive cultures, if we are talking about the low virulence microorganisms like coagulase or negative staphylococci, and of course if it is the case of a virulent microorganism like Staphylococcus aureus or Escherichia coli or another type of virulent microorganism, that grow in a single specimen, it is enough from the periprosthetic tissue or from the synovial fluid, and of course from the sonication fluid may also be of big aid. Of course, we must take into account the antibiotical treatment, if it is previous antibiotical treatment. Talking about the pathogenesis of prosthetic infections, from nowadays the biocompatible materials does not cause inflammation alone in the absence of an infection. And the problem with the prosthetic infections is that after implantation, the device is covered by the host proteins. This is why it favors the bacterial adherents, and the complement in the interstitial fluid can be activated by the surface of the implants, causing degranulation of local neutrophils. Also, there is another phenomenon like frustrated phagocytosis. It happens when granulocytes interact with the non-phagocytable surface of implants, and thus results in impaired granulocyte function. All these are for favoring aseptic loosening of joint prosthesis, but it is also need of an infectious microorganism to start the infection. If we are talking about the route of infection, there are two main routes, exogenous and hematogenous routes. The exogenous routes meaning the inoculation of microorganisms during surgery or early in post-operative period or even later via a penetrating event like trauma or local injection. The hematogenous route of infection, when microorganisms can sit on an implant from a distant site, from another site of infection, through bacteremia, of course, and the continuous spread. This is rare and implicates another focus of infection adjacent to the prosthesis, like osteomyelitis or another type of deep tissue infection. Radesh already told us very nice about the biofilm which protects the bacteria from antibiotics. And there are some exceptions, like rifampicin, which can eliminate biofilm-associated gram-positive microorganisms, and fluoroquinolones, which are active against biofilms from gram-negative bacilli. Because the biofilm has a unique property, protects the bacteria, and also under this or in this biofilm, the bacteria are not replicating. That's why most of the antibiotics are inactive for this kind of biofilm bacteria. The classification of prosthetic joint infections the infections and the routes are based on multiple type of criteria on the basis of the two major infection routes, exogenous or hematogenous, on the basis of symptoms, of course, simple, acute and chronic, and on the basis of interval from implantation, which can be early in the first 3 months after implantation, delayed between 3 and 24 months after implantation, and late more than 2 years after implantation. But the most useful classification is the acute hematogenous PGI, early interventional and chronic PGI. These are the most orientating types of classification if we are talking about the etiology and the route of infection. The risk factors for acquiring PGI are multiple, and the first category is the patient characteristics. It's very important. Another category is the surgery-related risk factors, of course, the post-operative factors and the risks during bacteremia. If we are talking about the patient characteristics, there are multiple characteristics. Nowadays, we are talking about a net state of polymorbidity of a patient, like a unique factor for each patient regarding these multiple type of comorbidities. And the most important ones are diabetes, obesity, rheumatic disease, and immunosuppressive therapy. But the other classical comorbidities, like congestive heart failure, chronic pulmonary disease, peripheral vascular disease, malignancy, coagulopathy, and so on, and of course the previous joint surgery, are contributing. It is always a debate about the asymptomatic bacteriuria between us and the surgeons because we are trying as infectionists to stop the abuse in the utilization of antibiotics, and that's why it's very clear criteria that the preoperative asymptomatic bacteriuria is not a risk factor for joint infection, so we don't have to search for asymptomatic bacteria and to treat it before the operation. It's another thing with the post-operatory tract infection, urinary tract infection. These are very beautiful studies that are endorsing the fact that all these criteria and comorbidities are risk factors for PGI. And here we have the socio-demographic characteristics that are implicated in this. We can see that even smoking is a risk criteria. And also the body mass index, it's an important criteria, especially if we are talking about a body mass index over 30. And of course, the medical and surgical history comparison and the risk of periprosthetic infection shows us that there are multiple criteria, and even if we, especially if we are adding criteria, if a patient has more than one comorbidities, the risk is more than evident. Of course, this meta-analysis concluded that all these factors are important for a patient with a prosthesis, and there is a new principle in a new team for infectious diseases about the frailty of the patients, which is a state of very low profile of health, which can predispose the patient to all kinds of infections, including PGI. About surgery-related factors, we know that the complexity and duration of the procedure can be a very important risk factor for the PGI. And of course, the prolonged operative times and multiple revisions at the same time can increase the risk for an infection. The postoperative factors are those regarding the wound complications. You know this better than us, the infectionists. Of course, the postoperative hyperglycemia and other risk factors which are not directly related to the surgery, like atrial fibrillation, myocardial infarction, and the prolonged hospital stay. These are the factors that can influence and can increase the risk for infection. The risks during bacteremia are very important, and we have these two classical examples about urinary tract infection, but in the postoperative period, and infection, not colonization, so it's symptomatic, which can increase the incidence of PGIs, but it's not a very important percent, it's 0.1. In contrast to this, the Staphylococcus aureus bacteremia, it's a very important risk factor, can increase the risk for infection with about 35%. And about these all risk factors, I found a very, probably you know this already, I found a very nice instrument to calculate the risk, which is an instrument developed by the American College of Surgeons, the risk calculator factor. I tried to calculate this, and it's very good, I think. And these are the summary of the American Academy of Orthopedic Surgeons, which are endorsing, of course, all these kind of factors and another type of factors, which can be took into account if we are talking about an individual patient, like active infection, anticoagulation, HIV status, dementia, and all other kind beside the one that we already know. About the microbiology, all microorganisms can cause PGI, including mycobacteria. And there are multiple studies that are showing us different type of profiles of infections. Of course, Staphylococcus aureus is the one with the most implicated in the PGIs, but we also have coagulase negative staphylococci, streptococci, gram-negative biaerobic bacilli, enterococci, and anaerobic bacteria. Less frequently diphtheroids and candida species, but this is a rising star, the candida. And of course, Cutibacterium acnes, which is involved in 3% of periprosthetic hip and knee infection and up to 38% of periprosthetic shoulder infection. And there are about 15% of cases with polymicrobial infection, and we must think about this if we have a situation very difficult to treat. Unfortunately, in 4 to 15% of cases, no microorganism is detected. And this is a very nice study, which is talking about the infections in the main etiology involved in each of Tsukayama categories of PGI. And we can see that in early postoperative infections periods, there are a lot of Staphylococcus aureus and also coagulation-negative staphylococci. But we also have gram-negative infections. And as long as we are getting distant from the moment of surgery, in the late chronic infections, we have coagulation-negative staphylococci more than others. And if we are talking about non-hematogenous PGIs, according to time index from surgery, we can see that in the early period, we have Staphylococcus aureus and gram-negatives a lot. And if we are going to 2 or 3 months or more than 4 months, the coagulation-negative staphylococci are the main type of microorganisms involved. The culture-negative periprosthetic joint infection is a very important entity because it involves about 5 to 45% of cases. There are a lot of factors that can be involved: antibiotic administration, inadequate culture medium, improper handling, improper sampling, inadequate incubation time, suboptimal number of methods, delayed transport, so many type of errors. But the etiology involved in these kind of cases is about fastidious bacteria, slow-growing bacteria like Listeria, Cutibacterium, Brucella, Coxiella, Mycobacterium, and fungi. And these are not identified by routine culture techniques. We need serological techniques or other type of diagnosis. For example, Cutibacterium acnes has to be cultivated more than 3 days to have a positive result, so it's about 6 days. A recent review estimated that the etiology of these culture-negative PGIs are about half of fungi, 43% mycobacteria, and 11% other types of bacteria. The biofilm Radesh talked about, it's a very important factor. And the clues for etiology in culture-negative PGIs is about the comorbidities. If a patient has a lot of comorbidities, we should think about fungal infection. If he had tuberculosis, we should think about mycobacterium. And about the fungal part, there are a lot of studies regarding the fungal infections, the fungal PGIs, and this is an example of that. 286 cases in a review of 10 years. The Candida albicans and parapsilosis was the main etiological agent in these patients. This is another study which reviewed the treatment methods for these fungal infections, which are systemic antifungals combined with the local antifungals. And I will talk 1 minute about Candida auris infection, which is an emergent infection with increasing risk for public health. There is already in the Romanian hospitals. With a high colonization rate and involved in hospital outbreaks and high survival rate on surfaces, medical devices, with rapid transmission rates between patients, almost like gram-negative bacilli, not like other fungals, and of course with a lot of biofilm formation. And this is a case that I found in a journal about a successful treatment, in this case, of a Candida auris intra-articular infection. So it was combined, the method with the antifungal, systemic antifungal therapy and local amphotericin in the cement, which gave us a lot of success in this case. And in conclusion, the etiological diagnosis of a PGI is the mainstay of a correct antibiotic treatment. The identification of the etiology of infection must start with correct sampling, site, timing, laboratory. And the empirical antibiotic treatment should be guided by the probable route of infection, the time interval from surgery, and the underlying significant risk factors, because the empirical treatment is the one that we are giving before any kind of identification of the microorganism. And the culture negative PGIs must lead to another test, so we must not leave out the tentative to identify the etiology. We must do another test regarding fastidious microorganisms, fungi, mycobacterium, and additional coverage. And don't forget about Candida auris, because it's a rising star in the Romanian hospitals. Thank you.
Thank you very much. And then again, Professor Ricardo Sousa talking about new biomarkers in PGI.
Sorry for being here again. Thank you, Haris. Routine diagnosis can be hard, and for us, especially for us surgeons, it's very tempting to have this tool that can offer this pregnancy test that can offer you an immediate result, and that this is what the industry often promises you. But let's see the evidence. Is it really like that or not? So what is a biomarker? Biomarker is something that you can measure. You can measure objectively. You can find it in blood or other bodily fluids. In this case, synovial fluid seems to be more important than blood tests. So we will focus on synovial fluid biomarkers. And regarding prosthetic joint infections, you'll see there is a continuum between aseptic and infection. There are a lot of prosthetic joints out there. We will focus mainly on the hip and knee. That's where the main evidence is. And there are a lot of different definitions. The previous speaker has told you about the IDSA definition, the infectious diseases definition, and they have different sensitivities and specificities. When we will look at that in this talk. But before we talk about the new biomarkers, we need to talk about what the old biomarkers are and what's their performance. And the old biomarkers, it's differential leukocyte count, the total number of leukocytes, and the proportion of neutrophils. Those are the classic biomarkers. And if you look at the literature, there's a very extensive number of proposed thresholds in the literature. And overall, they've got the sensitivity and specificity for the diagnosis of PGI around 90%. And of course, if you look at the lower cutoffs, then you will have a higher sensitivity. And if you look at the higher cutoffs, you will have a higher specificity. And that was the basis for those divisions that I've showed you previously in the EBGIS definitions, the 1500 and the 3000. And if you do the same exercise in the proportion of neutrophils, you will find the same results. So then going for the new synovial fluid biomarkers, and what do they offer? If you look on PubMed, there's a lot of interest in this topic in the last few years. And so we've done a systematic review of the literature and use papers only using one of those previously validated PGI definitions. And we found a lot of new synovial fluid biomarkers, and I can't talk about all of them. So they're mostly divided into cytokines and antimicrobial peptides. And we're going to talk about the four top research biomarkers. So the first one, and one that's in the market for longer, is alpha-defensin. Alpha-defensin is an antimicrobial peptide that is released from neutrophils to increase their ability to fight microorganisms. It has been shown in laboratory measurements, so ELISA tests. In 2014, this is the landmark paper on alpha-defensin. And since then, they've done a lot of research on this, and they found the specificity is consistently high with the laboratory measurement. And then the pregnancy test came out, the industry-driven pregnancy test came out, and there was some concern about maybe it's got limited sensitivity comparing to the laboratory measurement. And if you look at all the literature that's out there, and there is a lot of literature on alpha-defensin, you will see there is actually no difference between the laboratory measurement and the lateral flow tests. So what is the problem about limited sensitivity? The problem is which PGI definition are you referencing the test against? And this is a very interesting paper from the group from Andrei Trumpus that showed very limited sensitivity when you apply a more sensitive set of diagnostic criteria. So if you look at the literature under the eyes of which definition are the papers referencing the performance of the test against, you will find most of them is with the traditional MSIS or the traditional original ICM definition dating from 2013. And of course, sensitivity and specificity are very good. If you look at papers only with the ICM 2018 definition, so the newest definition, also performs very well. But if you compare it against some papers that use the IDSA definition that we've talked about, or the newest EBGIS definition, you'll see the sensitivity is much lower. So the test is not able to diagnose some infected cases. What about leukocyte esterase? This is the urine dipstick test has been long used for urinary tract infections. It's about 10 years ago, the first paper came out from the Rothman group, from Parvizi's group, and it shows a very high negative predictive and very high positive predictive in the extremes. But we are surgeons, we know often the tabs come out like this, bloody or messy, and this is not easy to read. It's equivocal to read. This is a colorimetric test. So you can do is you can centrifugate, but if you centrifugate, then maybe you have to adopt the criteria that you choose, not the +2 criteria. Maybe the +1 is more adequate, but let's look at the literature. So what it tells us is if you have a very positive test, a +2 positive test, it's very good specificity, but very low sensitivity. And of course, if you lower your threshold of interpretation, you increase your sensitivity, and of course, you lower your specificity. So this is a very cheap tool that maybe it's easy to use in your clinic. But what about what happens when you compare to different definitions? The same occurs about the American definitions, the old and the newest. There's maintained specificity, but when you adopt the newest, more sensitive definition, then sensitivity starts to come down again. What about calprotectin? Calprotectin is another protein that is present in neutrophils. It's been researched recently by our Dutch colleague Marian. 5 years ago, she showed us the potential of this to exclude the prosthetic joint infection, and then the industry came out with this lateral flow test, much like a pregnancy test again, but this has the advantage of being semi-quantitative. So it's not only a yes or no test, but it offers you some quantitative results. And what did they found? If the test is very positive, so more than 50 milligrams, so in the red zone of that test, it's got a very high specificity, also very good sensitivity. And if you compare it to different definitions, of course, this is a less well-studied biomarker, but it performs well in the older definitions. It performs well using the ICM 2018 definition. And there is one single paper that I was able to find comparing it with the new EBGIS definition. And it also, how do you go backwards? Here. And it also seems to show a very high sensitivity and specificity with the new definition, but this is only one single paper. It needs to be studied further. So the fourth ranking biomarker that we found in our systematic analysis was C-reactive protein in the synovial fluid, not CRP in the blood tests. So we all know this is produced in the liver, but it seems to accumulate in the joint, in infected joints. There's a lot of this is laboratory measurement, so this is not a point-of-care test. This is something that you can send to the lab. And there are a lot of different proposed thresholds, but often they perform quite well. And of course, the same if you have a higher threshold, higher specificity, lower sensitivity, and vice versa. What we've been using it is as an added adjunct, and you can use it especially when in the new definition, if you have in that yellow column that is difficult to interpret in the leukocyte count, so that 15 to 3,000 leukocyte counts, then if you add CRP, then you have an increased positive predictive value. So that's how we've been using it as an adjunct to normal. And I dare you to think also about this when you're talking about biomarkers. It's the price of them. So leukocyte count and proportion of polymorphonuclease is relatively cheap. This is prices from Portugal. I don't know the prices in Romania, but they can vary, but the proportion between them is the same. If you look at the performance of alpha-defensin and the performance of leukocyte esterase, they are not so different, but the price really is. And some of the original proponents of the alpha-defensin test have now clearly shown that it does not provide any additional benefit over leukocyte esterase. So be careful about this. And also about the new biomarkers, calprotectin is also not that cheap, and cynoval CRP is something that they can add in your laboratory routinely. It is not very expensive. So what are the limitations of leukocyte counts, and how can these new biomarkers help? Because there's times where leukocyte count is very elevated or very low that you really don't need to use these expensive biomarkers. But there are some selected situations they might think it might be helpful to use this new one. So previous antibiotic therapy is one of those situations where leukocyte count is very faulty. It lacks sensitivity because all the inflammatory response comes down with the use of antibiotic therapy. So it has been shown that antibiotic therapy produces false negative rates. That's a fact. How can you avoid this? You can delay surgery, or you can delay joint puncture, as we talked before doing the interpretation, or until you stop antibiotics for 2 weeks before doing the interpretation. And if you really need to do that interpretation quickly, then alpha-defensin seems to be a good test that is not affected by prior antibiotic administration. Leukocyte count in inflammatory arthritis, there is a lot of controversy in these difficult to diagnose cases. There are different proposals. Maybe the cutoff should be adopted differently or not. Actually, the literature seems to show that the cutoff should be the same, but the information that you get out of those cutoffs is less reliable than in normal patients, let's say normal patients for figure of speech. So the specificity is much lower in these inflammatory arthritis cases, so this is very hard cases to diagnose. But can these new biomarkers help? Well, alpha-defensin also seems to be elevated in inflammatory joint disease, as you can see in this paper. So right at the same level as PGI, so maybe not that helpful, although it seems to be the best alternative to neutrophil counts. If you compare the performance of synovial leukocyte count and alpha-defensin, alpha-defensin performs somewhat better in this context, but these are always difficult to treat, to diagnose cases. So metal-on-metal problems, metallosis, this is also very difficult to interpret leukocyte count in these cases. Specificity is very low in these cases. And in leukocyte esterase may be helpful here in these cases on metal-on-metal failure. Alpha-defensin is also very prone to false positive results in these metal-on-metal cases, so doesn't seem to be a good alternative. What seems to be working in this is to add synovial fluid C-reactive protein in these cases. So it has been shown that it can correctly reverse false positive cases, false alpha-defensin positive cases in this cohort. Actually, the conjoint interpretation of alpha-defensin and CRP may be helpful. If both are positive, then the positive predictive value is very high. If both are negative, then aseptic loosening is very likely. But synovial fluid CRP can falsely reverse those false negative or false positive cases in these metallosis cases. The other difficult to diagnose situation is periprosthetic fractures. Total leukocyte count is very unspecific in this case. Of course, there's the inflammatory response in response to the fracture. So the proportion of leukocytes or the proportion of neutrophils is not very informative in this context. And actually, there is no study on this specific cohort of patients using the new biomarkers. So how can these biomarkers help us in the future? Well, maybe the industry can make them cheaper, and we can use them all the time, and maybe then we can start to investigate their potential benefits over previously existing biomarkers. Or the alternative is to use them specifically on these difficult to diagnose scenarios because they are expensive and you shouldn't do it routinely. But then there is a lack of information out there on what is their real worth in these difficult to diagnose scenarios. So, or we can continue investigation and find better universally performing biomarkers. There's a lot of investigation being done, a lot of cytokines. Interleukin-6 seems to be the top ranking cytokine in the research studies. but if you look at their overall sensitivity and specificity, it's not that different from leukocyte count, and it's very hard to do in the laboratory, this one. This is not routinely available, so maybe not that a promising tool. And alternative peptides, there are some papers with some alternative molecules that seem to perform well, but there are a small number of studies there with a small number of patients, so they need to be studied further. So this is what the future can bring us, but right now we are not there yet. So again, multidisciplinary teamwork, work together with your lab, work together with your microbiology, with your chemistry lab. That's the way to do it. And of course, you're welcome to our EBGIS meeting. Thank you.
Thank you again so much. And then I would like to ask next speaker, Dr. Dr. Liliana Propertescu, who is an infectious diseases specialist and senior lecturer at the University of Bucharest, and also infectious disease specialist at the Orthopedic Clinical Hospital in Bucharest, to give us a lecture on the molecular diagnosis of PGI. Thank you.
Good morning, everybody, and thank you for your invitation. Well, new times, new diagnosis, new tools for diagnosis. Molecular diagnosis of prosthetic joint infection could be the answer to all those problems that you already show in your presentation. Okay, thank you. Already knows those criteria for diagnosis, but the good news is fact that this molecular diagnosis coming from behind and is applied for all those criteria, for all the samples that could obtain from the patient. Why molecular diagnosis? Because the sensitivity and specificity of those tests are increasing in the last years, and is situated between 70 and 90%. And very important, the turnaround time, so the time for obtaining the results is significant lower than the classical test. Now we are waiting for 4 or 5 hours. New tests show diagnosis, show results up to 45 minutes even. And in the same time, we obtain the identification of the germs, but also we obtain the resistance profile. That is very, very important to choose the optimal treatment. In my opinion, cost is the only limit of this method. Indications. I'm a clinician, and I try to find the indications for the problem that I found and I meet in my medical practice. And I'm asking, could be molecular diagnosis routine in an orthopedic surgery unit? Why not? And already there are many units that use frequent and in a regular way these methods. And for sure, next analysis will show us that our efficiency. I think one of the first indication of those tests, when the suspicion is high, but the biological samples are small, obtained from aspiration or from a guided biopsy. And purpose of identifying the etiological agent and defining the proper pharmacological and surgical treatment strategy. So it's a very good help in this situation. Another indication that I think it's very welcome, if we have to compare 2 or more bacterial strains obtained from the same patients, and especially if the antibiogram is slightly different. Sequencing of each strain could find the same genes resistance profile, because we know the germs are different metabolic state, and the energy is used for germ priority to be to adhere or to maintain or to multiply under the antibiotic pressure. So in this situation, I think the molecular biology is a very good choice. Another indication, sampling when the patient received already antibiotics, because the genetic test increases the rate of bacterial identification. Is one of the most frequent situation that we meet in our clinical practice. Always antibiotic is recommended. We have to wait some weeks before to perform classic test, but with using the molecular biology, we could have faster results. And also for the diagnosis of difficult to grow species, Mycobacterium, tuberculosis or other species, Brucella or something like this. Another indication is for patients in whom synovial fluid analysis reveals elevated neutrophil percentage, also a high white blood cell, and but the culture, so we have a high suspicion of infection, but the culture maintained negative for a prolonged period of time following surgery in the hope of isolating a possible infecting organism. We have many cases that we monitorize the patient, but we have not the precise diagnosis. Well, what method use molecular diagnosis? Polymerase chain reaction can be applied to different specimens, so we do not have to wait the culture. We can use the tissue samples, synovial fluid, sonicated prosthetic fluid. For sonicated prosthetic fluid, polymerase chain reaction has a better sensitivity, up to 75%, and the specificity is higher, up to 96 or higher. And a better numbers obtained if we have at least 5 samples with 2 identical strains. This increases up to 95% the sensitivity and up to 100% specificity. So are very good numbers for a diagnosis. Polymerase chain reaction could amplify even a specific single organism or a multiple bacteria, and it's called multiplex PCR. The problem with polymerase chain reaction is reproducibility, but new tests will solve this problem because commercialized multiplex PCR are more friendly with clinicians, so, and with the lab staff. This is a kind of results, or how will look results from using PCR with biofile joint infection panel. We have for gram positive, we have for gram negative, and also for fungus. In the same time, we have the gene resistance profile, sorry. And another molecular diagnosis method, it's broad range, 16 subunit, ribosomal subunit, is a base pair gene, about 1,500 base pair gene, and this genome has a very well conserved region that help us to diagnose the infection, the bacteria, and a small variable sequence that help us to identify the bacteria. So it's useful also for diagnosis and to identify. Is able to detect the viable and non-viable microorganisms. It's useful for identification also the bacterial pathogen in pre-treated patients with antibiotic. Of course, there are some secondary inconveniences because DNA sample contamination caused 4 positive results. That incapacity to distinguish between living or dead bacteria and DNA contamination represent the main limitation of PCR based on diagnosis yielding because we obtain false positive results. But the next generation sequencing, called NGS, is a massively parallel sequencing technology that offers ultra-high throughput, scalability, and speed. Exploits the high conservation region of the 16 subunit, and the variable, help us to identify the bacteria species. It's very versatile method because could identify in shallow, or could perform a deep analysis of a single genome. The advantages of this method, because is enabled to identify the bacteria species which are fastidious, are slow growing, and could detect a crowded field of pathogens working very well with polymicrobial samples. In conclusion, computing era complexity means equal with complexity in speed. This molecular biology is the most adequate way in medicine, not only in diagnosis, in treatment, in vaccine, and in prophylaxis. Let's see the last period, the last pandemic challenge. The key was coming from bacterial biology, molecular biology, sorry. And from my point of view, very important for a clinician especially is to understand what this specialty could offer us to know what expectation to have. Thank you very much.
Thank you, Dr. Liliana. I'm happy to ask Professor Olivier Guyssens from the Department of Nuclear Medicine at Clinique Universitaire de Saint-Luc in Brussels. He is also the chair of the European Association of Nuclear Medicine in Inflammation and Infection Committee, so he's the right person to talk about nuclear imaging techniques in PGI. Thank you.
Thank you very much for the introduction. It's my pleasure to be here, and I'm very glad to have the opportunity to talk about the nuclear medicine imaging techniques in PGI, which I hope will nicely complement the excellent talk from Professor Souza on the recent FGIS guidelines. But before that, I would like to show that nuclear medicine has become a very important tool in the assessment of a wide variety of disorders in which I call the 3 I's: infection, inflammation, and immunology. And this has been exemplified by the fact that nuclear medicine imaging techniques have been implemented in several clinical guidelines. Think about endocarditis, vascular graft infections, vasculitis, and now also recently in the new FGIS guidelines. And shown here is an overview of our diagnostic toolbox. All different available radio tracers that can be used to assess infectious processes. But of course, in routine clinical practice, we mainly use labeled white blood cells, fluorodeoxyglucose, and in some centers, they still use gallium citrate. Now, which nuclear medicine techniques can we use to assess musculoskeletal infections? I think there are 4 main modalities. It's the standard bone scintigraphy, white blood cell scintigraphy, bone marrow scintigraphy, and finally FDG PET-CT. And those modalities can not only be used for prosthetic joint infections, but also for peripheral bone infections. And so what I would like to show is the role of these techniques in the assessment of PGI, refer to the current guidelines, and discuss more in detail the diagnostic flowchart that had already been briefly shown by Professor Souza. Bone scintigraphy. It's the standard exam, technetium labeled biphosphonates, that actually reflect the osteoblastic activity, bone remodeling. And of course, it has the advantages that it's a very high sensitive technique with a very high negative predictive value. So when the scan is negative, we can almost rule out infection. Moreover, it's a very fast imaging technique, no waiting list, relatively cheap, but the downside, of course, is that it's non-specific. So there could be uptake at all sites of increased bone metabolism independent of the underlying pathophysiological process. And especially in the setting of PGI, bone scintigraphy can remain positive up to 5 years after prosthesis implant. So this is something we should be aware of. And in case we have a positive bone scan, it should always be complemented by another imaging technique to make the differential diagnosis between an aseptic process or an infectious process. Shown here is an example of a 3-phase bone scintigraphy. On the top, I'm not sure how to remove this. Apologies, I'm not sure. So on the top left, you see the first phase, which is reflecting the perfusion phase. And then after 2 minutes, we have the second phase, the so-called blood pool phase. And here you can see 2 examples of 2 patients with a hip replacement, in which you can see that in both cases, there is an elevated blood pool. And then we perform the late static phase, which you can see on the bottom of the same 2 patients, which showed a moderately increased uptake along the total hip prosthesis. Now, when we see these images, for me, it's impossible to make the differential diagnosis between aseptic loosening or an infection. Now, it turned out that patient A had an infected prosthesis and patient B an aseptic loosening. So whenever we see uptake on bone scintigraphy, we should complement it with another technique. And as I mentioned, in hip prosthesis, it can remain positive up to 2 years and even up to 4 or 5 years in knee prosthesis. White blood cell scintigraphy is the gold standard for bone and soft tissue infection for years. And the best radionuclide to use is technetium-labeled white blood cells, and it's a specific indicator of leukocyte infiltration. And this technique allows us to differentiate infection from inflammation with a high diagnostic accuracy. But the downside of this technique is that it requires a very laborious preparation. We need to take blood of the patient, we need to prepare it, we need to radiolabel it, re-inject it under sterile conditions. So it's a very time-consuming process, and it also exposes our technicians to radioactivity and potential contaminations. But what is important when we perform white blood cell scintigraphy is to remember that in infectious processes, the accumulation is a dynamic process. And this is shown here on the bottom. When we look at the infectious processes, whether it's being acute, subacute, or chronic, shown in green, we can see a progressive accumulation of leukocytes at the site of infection over time. When we look at the yellow curve, which reflects an inflammatory process, we can see that it peaks around 3-4 hours after tracer injection, but then there is a slow washout of tracer. And this is the reason why we perform dual time point imaging when performing white blood cell scintigraphy to make this differential diagnosis between inflammatory process or infectious process with higher certainty. And so this is shown here. We perform dual time point acquisition after 3-4 hours and then after 20 or 24 hours, and we first perform a visual analysis. When there is an increase in signal intensity or an increase in extension of the signal, then it's highly suggestive of an infection. When there is a decrease in signal over time, it's rather suggestive of an inflammatory process. But of course, we also have equivocal processes. And in those processes, semi-quantitative assessment could help us to differentiate infection from inflammation. So here on the left-hand side, we see an example of a pure visual assessment. On the top, we see the bone scintigraphy. The early phase on the left panel, increased blood pool, also moderately increased uptake on bone scintigraphy around the hip prosthesis. On the bottom, you can see the dual time point white blood cell scintigraphy. And I think it's clearly seen at 4 hours there is no pathological uptake, but when we look at 24 hours, you can see a moderately increased accumulation of labeled white blood cells at the tip of the prosthesis. So this is an infected hip prosthesis. Here on the right-hand side, an example of semi-quantitative assessment. Again, 4 hours acquisition, 24 hours in a patient with a knee prosthesis. Now for me, I have to admit, when we look visually at these images, it's nearly impossible to say whether or not there is an increase in the signal. But what we do in those conditions is we draw a region of interest around the knee prosthesis, and we take the contralateral side as reference, and then we look at the target to background ratio, and in this case, we could see an increase from 1.1 to 1.4, again suggestive of an infectious process. Shown here are some other examples. Again, always dual time point imaging, 4 hours, 20 to 24 hours. In patient A, we can see uptake around the knee prosthesis with a decrease over time. So this is non-infection, whereas the other two cases, we can see an increase in uptake over time, and on the bottom, not only an increase in uptake over time, but we can also see the appearance of a fistula in the soft tissue. So no infection, and the two other cases are infectious processes. And now when we apply these standardized acquisition and interpretation criteria, we obtain a very good diagnostic accuracy of around 90%, both in hip and knee prosthesis. And this has also been shown in a study by Paola Erba from Italy, that when we adhere to these standardized acquisition and interpretation criteria, in this study you can see the diagnostic accuracy 98% for both hip and knee prosthesis. So to summarize this interpretation algorithm, a qualitative analysis when there is a decrease, no infection, increase, infection. In doubtful cases, we can go for a semi-quantitative assessment regarding target to background ratio. When there is an increase, and we usually apply a cutoff of around 20%, it's very suspicious of an infectious process. But in some cases, it remains doubtful, and then we can complement our imaging techniques by bone marrow scintigraphy, in which we look at the match or mismatch pattern between the white blood cell scintigraphy and the bone marrow scintigraphy. It's an easy imaging procedure. We inject a radio tracer and we perform imaging after 1 hour. We use the same projections as for white blood cell imaging, and we perform a pure qualitative assessment, being a match or a mismatch pattern. Shown here is an example, 2 patients with a hip prosthesis. In patient A, on indium-labeled white blood cells, we clearly see a pathological, or we think a pathological uptake at the trochanter region. The same for patient B. Is it infection or not? Very difficult, but when we complement it with the colloids, we can see that in patient A, there is a perfect match between the accumulation of white blood cells and the bone marrow. So this is non-infection. Whereas in patient B, we can see that there is uptake in sites in which there is no bone marrow activity, so patient B has an infected hip prosthesis. Here are some other examples. On the left-hand side, perfectly concomitant between white blood cell and colloids. On the right-hand side, we see a pathological uptake. Now, with the introduction of hybrid SPECT-CT combining anatomy with physiological information, it has further improved our diagnostic accuracy, not as much in PGI, but mainly in peripheral bone osteomyelitis. This is an example in which we can see a pathologic uptake of white blood cells around the ankle, but the question is it pure osteomyelitis, or is it also a soft tissue infection, or is it a combination of both? And when we perform SPECT-CT, we can clearly see that the uptake of white blood cells is limited to the soft tissues and not to the bone. Briefly, some words about FDG PET-CT in the workup of prosthetic joint infections. So we all know that FDG PET is a versatile tool for inflammatory and infectious processes, which is based on the uptake of glucose in the cells. Briefly, the mechanism, FDG is transported intracellularly by the glucose transporters. It gets phosphorylated inside the cell, but in contrast to glucose 6-phosphate, it's not further metabolized in the glycolytic pathway, and therefore it accumulates in the cell. The advantages, it's a one-stop shop with diagnostic CT. It's an excellent tool for a variety of inflammatory or infectious disorders, and the report is readily available. We inject a radio tracer, 1 hour afterwards we perform the imaging, and we already have the result. But the disadvantage, it's a non-specific tracer. It's impossible to differentiate between inflammation, infection, or even malignancy. So, shown here are the differential diagnosis of FDG uptake. It could be osteomyelitis, inflammatory processes, neuroosteoarthropathy, bone fracture, granulation tissue. All these pathologies will take up FDG. And when we look at the performance of FDG PET-CT in PGI, we can see large ranges of sensitivities and specificities. As you can see here, sensitivities by the group of Stumpe, 33%, other studies 100%. This is also shown here in a recent meta-analysis at the bottom. Very variable results. And the reason for this is that there is a lack of interpretation criteria. And most people, when they use FDG PET-CT, refer to the Reinhardt's criteria, and these are shown here schematically, but only the score number 5, in which there is periprosthetic soft tissue uptake, is considered positive for a prosthetic joint infection. So this is a very narrow definition, because it means every FDG uptake along the prosthesis is not considered an infection. Several people try to look at quantitative information. Can the intensity of uptake help us to differentiate? But as you can see here on the right slide, the standardized uptake value cannot help us to distinguish aseptic loosening from an infectious process. But however, it does not mean that FDG PET-CT has no role. For example, this is a case from our hospital, a total knee replacement, left side 2002, right side 2013. Patient presented with fever, but we can see here on the left knee, there's a heterogeneous FDG uptake in comparison to the right knee. So this is an infected knee prosthesis. This is another example, total hip replacement 20 years ago. Patient presented with fever of unknown origin and positive hemocultures. Now, when we look at this patient, we can see several regions of pathological uptake along the spine, corresponding to spondylodiscitis, but we can also see on the right bottom a pathologic uptake around the right hip prosthesis with extension towards the soft tissues. And this is the reason that in 2015 we started a multi-society project to establish a guideline for the use of imaging techniques and the workup of PGI. This was a joint initiative between the EBGES, the ESHMID, the ESR, and our society, the European Association of Nuclear Medicine. And I will just briefly describe you this flowchart to end the presentation. So when a prosthesis has been placed more than 2 years ago, then the first examination would be a 3-phase bone scintigraphy or FDG PET. The reason is that these are 2 techniques with a very high sensitivity and very high negative predictive value. So if they are negative, we can rule out infection with a high certainty. When they are positive, of course, we should complement it by, for example, white blood cell scintigraphy, and then we can apply again the diagnostic algorithm that I've shown before. Within 2 years of a prosthetic implant, I think we should immediately move towards white blood cell scintigraphy, knowing that the bone scintigraphy will be positive, and again, we apply the diagnostic algorithm. If there is an increase over time, infection, a decrease non-infection equivocal, we go to the semi-quantitative approach. So thank you very much for your attention.
Thank you, Professor Olivier. Well, by this point, we have learned somewhat about diagnosis. It's now my pleasure to ask Professor Richard Trebsche from Slovenia and the past president of the European Bone and Joint Infection Society to talk about surgical treatment strategies. And you can save your questions at the end of this discussion. We will have, at the end of this presentation, we'll have discussion for the session. Thank you.
Thank you, Ricardo, for this kind introduction. So, in this presentation, I'm going to overview the surgical strategies for PGI treatment and mostly focus to go over the discussion between 1 and 2 stage, because I think it is not a discussion at all, because an algorithmic approach, in my way, is the only way how to approach prosthetic joint infection. So we know that prosthetic joint infection can present in a really many different ways, ranging from completely asymptomatic infections to high-grade acute infection, with most of the processes being in between. And the diagnosis is paramount. So I think it is very important to use this practical EBGIS criteria in order to have right diagnosis before surgery, because there are many differential diagnoses that can mimic any type of infection, including high-grade ones, and these are metal ion disorders, crystallopathies, through metal allergy, hematoma resorptions, and also other possibilities. And it is appropriate to organize the diagnostic process in an algorithm, so you do always the same diagnostic application, and then to have the right diagnosis in order to proceed to surgery. So we have many surgical options, ranging from debridement and retention, which gives nearly a normal function afterwards, down to permanent removal of the implant, with a very, very poor functional result. That's why I think it is important to go algorithmically, because then you can select the least invasive treatment option with the best functional result without compromising the cure rate. Before going into how to decide about the strategy, we need to acknowledge 2 concepts. One, it is the concept of debridability. What does it mean? Debridability means the ability to perform complete debridement of a joint. So if you have a sinus tract extending through the acetabulum into the pelvis, of course, this is not debridable. And if you have a sinus tract behind in the knee, in the popliteal region between the vessels and nerves, so it is not debridable. It means that those patients are not suitable for less invasive treatment options. And the other concept is the concept of anti-biofilm antibiotics, which means that certain antibiotics are better fitted to use them when we have an infection associated to a foreign body. Then we have different surgical strategies like debridement and retention, 1-stage replacement, 2-stage replacement, and now we will discuss how to select each of those. So debridement and retention, or DARE, it is good for acute infections independent on the type of or the origin of this infection. Mostly we need to have early or late acute infection. We need to have debridable joints, stable implants, and of course the right bug. But with acute infection, we don't know always whether the bug is okay or not, but still in an acute infection, we need to proceed with the debridement and retention. What mistakes can we do with debridement retention? The most important is to misjudge the length of the duration of the PGI, particularly in late acute infections, because many of those are acute exacerbations of a chronic infection. And if we treat them with debridement, of course, we will fail. Of course, if we are not able to debride the joint completely, or if the joint is inherently not debridable, it is also a mistake if we do it there. The results are very variable, but I have my own experience with more than 200 dares in my career. Until 2004, we had 86% cure rate with those couple of few in the beginning. But the last 100 presented at EBGIS, we achieved 95% microbiological cure rate in those infections. So it can be it can be cured in certain cases. So one-stage replacement, it is one surgery, better functional results, easy acceptable for the patients. But the problem is that some centers use this approach for all comers, and they need to cut out everything. So soft tissues, tendons, bones. Of course, if you use it for those, it is a very weak functional result at the end. So when to decide for one stage? Well, it is the best for chronic low-grade or mid-grade infection, where the joint is debridable, and of course the bug is sensitive to antibiofilm antibiotics. This is a case of a chronic infection, a patient after sepsis with bilateral symptoms, elevated CRP, and the diagnostic procedure showed that it is a chronic Staphylococcus aureus infection on both sides, and it seemed debridable on the imaging, intraoperatively as well. So we performed a bilateral one-stage replacement with appropriate antibiotics, oxacillin plus rifampicin afterwards for 3 months, with an excellent functional and also function and microbiological cure. So what mistakes can we do with one stage? Mostly, if we misjudge the extension of the sinuses, we do a poor debridement, whether we don't know how to do it or it is not possible to do it, and using it, as I already said, for all comers. Two-stage replacement is for many a gold standard. It does have a high microbiological cure rate if used, when we use it for all, but it gives a very inferior functional outcomes, and it's complex for the patient and the relatives. Actually, it is a catastrophe, because look at this slide. You have many patients that die and so on. That's morbidity and mortality is very high. So it is, the question actually is it is still a place for two-stage at all now? But I think, yes, it is. When you have a very complex patients, like maybe this one with a concomitant infection of a total hip and total knee, plus a fracture in between, a complex flora, of course, I think not a lot of surgeons would go with one-stage replacement in these patients. So these patients are those that really need the two-stage approach. So the indications are the germs that are resistant to antibiofilm antibiotics, and of course, when complete surgical debridement is not possible. What are the pitfalls with two-stage? Where mostly if we do a suboptimal debridement and some hardware remains in the joint. But the most important is that if we use it for everybody, it is over-treatment for many. So this is an interesting case of a patient that several times was debrided, never achieved the success unless the screw below was, until the screw below was removed, because there was a purulent collection down around the screw, and after the screw was removed, we were able to sterilize the joint and do the second stage. So two-stage implantation is suitable for some patients, over-treatment for many, but there are some technical aspects to improve function. And the best is the adductor anatomy in order to be able to using intraoperative or operative function when we have patients. So yes, the two-stage replacement is here to stay, but mostly for the very complex patient with shortening, difficult organisms that we need to several spacer exchange. So to back up the surgical part, we need antibiotic algorithm as well, when the base is the bacterial susceptibility, bactericidal strength, good bone penetration, and antibiofilm activity. So when we have an intravenous phase in the beginning, we try to stay on the right side with bactericidal antibiotics, but when we switch to the oral phase afterwards, we need antibiotics that go deep in the bone with high concentration, and of course, if they have antibiofilm activity, it is even best. I think it is very good to have an algorithm for those, even though you work with an ID specialist, because to have repeatability, you need to treat the same infection always in the same way. And I really would like to encourage you to read this Daniel Kahneman Nobel Prize winner book, which shows that even the worst algorithm you can have, it is still better than chaotic treatment every patient in a particular way. And of course, you need a good team in close cooperation within a well-organized bone infection unit in order to achieve functional success in PGI. So diagnose early, keep diagnostic threshold low, select the least invasive surgical approach, and use antibiofilm antibiotics. Thank you very much for your attention.
Yeah, thank you, Richard. I think we'll open the floor for discussions. Are there any questions from the floor? So I'll start the discussion if you don't mind. I would like to ask Dr. Liliana Precesco. Yeah. Is there a microphone in the room?
Yes?
Yeah, thank you. I enjoyed your talk very much, and I was very curious to find that the only con that you see against molecular diagnostic techniques is the cost. What do you think about, are we at the stage where we can interpret the findings, especially from the next generation sequencing that you talked towards the end of your talk? Are we at the point that we can interpret those findings correctly? Do you know what everything means? Is price really the only con?
In my point of view as clinician, yes, because it's mandatory to have a very good relation with staff from genetic lab. It's the diagnosis and interpretation should be done by the specialist in molecular biology. And in our unit, we have a special department of molecular biology who help us. Sometimes they perform some home-made primers, so on and so on. But in my opinion, yes. Thank you.
Is there any other question for the audience, for all the speakers? Yes, please. No, yes, please, please.
Here.
Thank you. I have a question for Raresh. I want to ask him, he showed us some slides with the influence of antibiotics against biofilm. And you show us images with beta-lactams, with vancomycin, but you didn't show us slides with rifampicin and fluoroquinolones. There are information regarding how to use these antibiotics to have an antibiofilm activity.
Yes, indeed, I didn't show you data regarding rifampicin. We will have a separate presentation, the next session on rifampicin, and you will receive plenty of information on that.
I also have one question for you about the next generation sequencing. Like we did a study a couple of years ago, and we compared our results of next generation sequencing with our results of PGI, and actually we found that there was a high degree of contamination with the abdominal flora. So we did not even consider this technology because we did not know how to interpret it and if it is possible to get out the clear result without that. How can we avoid that? Do you have any suggestions for that?
Yeah, you're right. This is omnipresent problem, but not only for NSG or for molecular diagnosis, it's also available for the classical method of culture, because many times we have results and we think that no, it cannot be a gram-negative, it's very probable contaminated. It's not specific for molecular diagnosis, this problem.
Yes, but we also did some primary joints without infection, so before implanting the knee or hip, and still there was a lot of contamination with the DNA from the gastrointestinal tract. So probably this DNA is traveling around the body, and it's difficult then to know which DNA is just related to the joint and which one is just going around the body.
Yes, but it could have the next test could be more accurate to show which one is implied in this infection or not, because we have many places to take samples, you see, and we have to compare these results, but are more specific than the classical culture and the tools.
Actually, I want to mention something. So NGS is not a test that is made routinely, so it's not necessary for all patients. If we could establish the etiology with culture, it's better. And it's not only better, but we have the antibiogram, we have the possibility to treat. We know exactly what antibiotic is necessary to treat. With NGS, with PCR, we don't know anything about the susceptibility, and actually we recommend, or it's recommended, this NGS in patients in which the infection is obvious, so we are sure that it's infection, but we don't have any other possibility to establish the diagnosis, because if we treat Propionibacterium agnus in a patient without any sign of infection, I think it's not correct.
Just to add, it's true that novel panels also include some mechanisms of resistance, but still it's not all the antibiogram. And especially for PGI, the novel BioFire panel does not include Staphylococcus epidermidis. So a negative result is maybe useful, but must be interpreted with caution.
I have a question for the surgeon. Actually, Professor Sousa told us the guideline in order to diagnose the PGIs. And at one point, the talk was about punction, but sometimes punction of the hip or the knee of the joint repeatedly can be false negative. And it's a questionable gesture. And how do you comment on this? How frequent do you use puncture if you suspect a PGI? And the next question is, if the puncture is negative, an alternative is arthroscopy. But in arthroscopy, I have no experience with that. But, you know, judging PGIs and tumors, arthroscopy is to avoid in tumors because it's spreading the tumoral cells. If you are using in PGIs arthroscopy, you have dilution. Dilution is not questionable because not quantity of the germs it's counting on infection, but also the liquid can spread also the germs in the infection. So it's a little bit for me a doubt in using arthroscopy when you suspect a joint infection, because if you have a confirmation, obviously the next step you cannot provide a dire, so debridement, and if you use arthroscopy or somehow, how can you answer at that?
Yes, well, we do puncture every revision, and it's actually easy for the knee. Our radiologist does it, who does maybe 10 punctures a day, so they are very skillful. And they use imaging technology, usually ultrasound or CT scan. So with the CT scan, they find the pouch of the liquid, and then they go directly to the pouch, so it's very rare that it is a dry tap. So, and then we use the diagnostics on what we have, and if of course, microbiology, then cell count, and sometimes also other modalities, and based on that, we decide our treatment. So if it is positive, either cytology or microbiology, that's okay. So you have a stone in the mosaic of the diagnosis, and you can already proceed based on this, whether into a septic way or into an aseptic way. Then we have the possibility to do intraoperatively. So we aspirate, and within 20 minutes we have the cell count available. So we can decide also then how to do. With the negative result, and if there is a problem, but you don't want to you don't find the diagnosis, we also did a small study with the arthroscopic sampling, but it's actually, I think arthroscopy is not appropriate because you go in and out with that, so the level of contamination was really high. That's why I think mini open procedure for taking samples for histology and also the liquid is far better in terms of like contamination. So then if we have a problematic joint, then we have the liquid, there is nothing. We know that there is nearly only one possibility. So it's usually Cutibacterium of some type. Because all the others have elevated cell count, and also others can be detected on bone scan, but Cutibacteria mostly not. They can have even lower cell count than usual. So if it is this negative, then we need to tailor, and we try to use an anaerobic culture, hemoculture bottle, and after the end, if we don't know what to do, and it is not an acute problem, we try not to do anything. So just wait and repeat the diagnostic procedure, maybe after 3 months and so on, and to discuss that with the patient.
Thank you.
To expand a little bit this conversation, I would like to ask Professor Goessens if in total hip arthroplasty would you suggest the MRI with suppression of the fat or some more sophisticated techniques in order to avoid to make punctures again and again?
Yeah, there are a couple of studies on MRI, but the results are quite discordant. And I think it's a little bit similar to FDG PET in prosthetic joint infections, that we actually lack clear interpretation criteria. I know one center in the US that routinely performs MRI. They obtain very good results, but if you want to extrapolate this to other centers with less experience, they don't obtain the same results. I know with fat suppression it might improve, and some novel sequences, ZTE or STIR, etc. But I highly doubt that it could replace white blood cell scintigraphy or a more specific test. That's my personal opinion.
Would you like?
I want to mention something and to ask something. I want to mention I'm infectious diseases specialist, but I think that for you as surgeons, as orthopedists, it's very important to have a good collaboration with the laboratory, because if you don't say to the microbiologist what you need, be sure that the sample will be on the blood agar, and you will have the result after 48 hours. Because this is what happened in the lab. But actually, if you have a patient with a joint infection, it's important to say it's probably something else. So try on different media or try on more media to have a result, and keep more than 48 hours, maybe keep more than than 1 week. For example, in endocarditis, we always collaborate with the microbiologist and said, move the bottle from the incubation machine in another one after 7 days, because it's possible to have something that will grow later. This is what I want to suggest. And the question is for Professor Sousa. You said that, for example, in dry tap, it's possible to inject saline water or to inject something to help. And there are discussions in the literature that this procedure is possible to make contamination, or it's possible to inhibit the growing of bacteria. Can you comment something?
Yeah, thank you. And because it ties with the question from the gentleman. There is also the theoretical possibility of contamination when you do that. That's why I stress that you should only do that in a really aseptic environment. So to answer your question together with this one, everyone's got their own cookbook, because this is a very gray area. What we do is we take those patients to the OR, so completely sterile, and we inject it absolutely sterile saline through a small needle, and then just wash the joint and then collect some fluid. We do it like that. The contamination, of course, theoretically is always possible, but it has been shown in large series that it really correlates with the interoperative findings later. So the contamination rate is really, really, really low. Of course, every invasive step is possible, is a potential contamination step. It's the same with biopsies. Personally, we do use percutaneous biopsies. You can do synovial biopsies, bone biopsies. We don't do arthroscopy because I think it's very much more prone to contamination. Again, I agree with that step. But those are steps that you can do, and those will be we're talking about the 10% or 20% of cases. Most cases you will have a definitive answer with the joint. So we're talking about the boundaries, about the gray area. I agree, contamination is always possible, but it's not a problem if you do it in a sterile fashion. Yeah. One last question, and then.
How can I do? I'm orthopedic surgeon, and I believe in you, like all the help, like laboratories, like infectionist doctors and microbiologists. We need you. For that reason, we organized that meeting, to be both, and orthopedic surgeon and you. My problem is, do you have a possibility to separate contaminated results from the positive one, really? Because it's a very long way between theaters, between the point to take some probes about sonication, including sonication, and the other kind to take a probe. Which one can be deselected because it's a contaminated one? For me, it's a very serious problem. Multiple probes, it's okay, because you have 5, 7, and you can decide if it's a multiple probe positive to take in account. Is it other way to do something like that?
I can answer from the orthopedic surgeon side. That's what I do. I'm a surgeon also. And probably Fatima will answer from the other side. You take everything into consideration. That's why we are always talking about multidisciplinary teamwork. You need to have things considered together. Clinical information, leukocyte count information, how is the wound healing, all those clinical informations that you need to interpret together with the microbiology. I don't think, as a surgeon, I don't think it is possible for microbiology alone to tell me this is a contamination or this is not a contamination, because the microorganisms are the same. So I believe in multiple inputs from multiple specialities and also the clinical information.
Yes, I totally agree. We can talk for hours, but now we are run out of time. So we thank you, all of you, and Professor Sousa.